welcome to this webinar. My name is Adam Kalinowski, and I'm the president of the Dystonia Europe. I know that many of you have been working or learning all day remotely front of the screen, so I thank you for taking time to come to this webinar. This is the fifth webinar in our series. So I'm going to hand over now for a few opening remarks to Monica Benson, Dystonia Europe Executive Director. Enjoy our meeting. Monica?
Thank you, Adam. Hello, everybody, and I also would like to welcome you to this webinar, our first webinar this year, but the fifth webinar in our webinar series. And today, the topic is keeping DBS battery charged and on to maintain neuromodulation for dystonia in childhood. And this will be presented by Paediatric Neurologist, Dr. Jean-Pierre Lin from Evelina Children's Hospital in London. And today's session will be moderated by Neurologist Dr. Katarzyna Śmiłowska from Poland. And she will keep track of all the questions that you have, and Dr. Lin will try and answer as many as possible after his presentation. And yes, I wish you a good webinar, and I will give the word to Kasia.
Thank you, Monica, and thank you, Dystonia Europe, for organizing this webinar. I welcome you, everyone, and I really and strongly encourage you to ask the questions, because this is a tremendous opportunity to ask Professor about everything that you have in your mind. And I will make sure to deliver those questions and answer everything that that struggles you. So I give the floor to Professor Jean-Pierre Lin, and enjoy the meeting.
Well, thank you very much, Adam, Monica, and Katarzyna, for the setting up of these seminars. I hadn't actually realized that this was the fifth seminar, so I'll need to do some homework and find out what the first four seminars have been. But I have to say that I'm quite nervous about the working online, because it's still, for me, a relatively novel technical change in the way we normally do business. I'd like to also acknowledge that I've been a medical advisor to Dystonia Europe for a number of years, and it's a very great pleasure to work with this large European organization, as well as our own UK Dystonia Society, who had an annual meeting a few months ago in the autumn, and where we successfully discussed topical issues largely related to being confined and owing to COVID. So this is a picture that goes back several years of our complex motor disorders service at the Evelina London Children's Hospital, and it's almost as if we were on a different planet, because there are people from many different countries of Europe, as well as Australasia. And some of the people are permanent members of the team. Some of them are still working with us, including myself, and some are visiting fellows. And I just want to emphasize that in order to practice good clinical medicine, share ideas, and publish them in studies, then we need strong, robust relations between different nations and interested and enthusiastic people. Let's hope those days come back again soon.
Can you reach out towards Mum with your arms for me?
Now,
try and stretch your arms out towards Mummy.
Illustrate a number of issues about what happens when the deep brain stimulator is switched on. Here in the top
Can you bring your hands
picture,
together at all?
you can see that there's a girl who is arched
I
back,
know it's difficult.
her tongue is
Yeah.
repeatedly
Okay.
sticking out, the eyes are deviated upwards, and she's in a very uncomfortable position and has been so for 5 days. After her deep brain stimulator was
Still
switched
at those
off.
high voltages first.
And in the third panel here, at 11:45 on a Saturday morning, the stimulator is being switched on, and you can literally watch the dystonia resolving, associated with very, very forceful breathing through the nose. And I've just switched her on, but I had absolutely no idea that switching on the stimulator would actually have such a dramatic effect so quickly. I should also say that the reason the stimulator was off was that 5 days beforehand, when I was interrogating the stimulator, the programmer developed a software fault and switched the stimulator off. And it took me 5 days to get a new programmer.
It's still at those high voltages first.
Back in 2008. And here in the fourth panel,
Off you go.
is only at 12:07. So 12 minutes after starting the switching on, you can see the dramatic change in the quality of the posture, facial expression, which is smiling.
Quite difficult, isn't it?
And we give her 40 minutes just to be certain that things are stable.
Like in the London
Start
Marathon.
drinking. And to me, it's as if I'm now dealing with a young athlete who has run a marathon and is having a rest, a well-earned drink.
Very.
Now, what's more interesting than simply having switched her on is that she has a complex
This is less than an hour after
neurodegenerative
switching
disorder,
on. Now she's drinking
which
waffle.
is very, very difficult to manage. And the fact that we can restore such function after 3 years of deep brain stimulation
I don't think so.
is really quite remarkable.
Yeah.
And I have to say that this pattern of being switched off has happened another 3 times over the next perhaps 3 to 4 years. So that if we don't know about the effects of switching off, we can't really advise parents, we can't advise children and young people,
Like in the London Marathon.
we can't make the right diagnostic formulation of why somebody may suddenly develop severe dystonia, which this is called status dystonicus, and we are very much in the dark. So knowing whether or not the battery is delivering neuromodulation is absolutely vital. Now I have a series of
You're going to have pudding first.
illustrations about what happens when the stimulator is on and when it's off. This is a pre-operative video of a boy with a DYT1 genetic dystonia. His movements are very chaotic. I've shown this on a number of occasions at different meetings over the last 12 years. The amazing thing is that he does manage to eat his mousse and finish his dinner, but he has to do it on the bed.
You're going to have pudding first.
And very shortly, about a month after having had his DBS, which is remarkable, he can sit at the table and he's eating in a more normal way. This is just to illustrate everything that happens 4 months after DBS, 6 months after DBS, and finally, almost normal movements 2 years after DBS. And the purpose of having all of these different phases of the DBS is to illustrate how long it takes for neuromodulation to unravel the dystonia. People expect a light bulb effect, but it isn't. And at every intermediate stage, this young man and his family were concerned that the DBS wasn't working. And yet, compared to the original condition, it's quite clear that the DBS is working. Now imagine if, without realizing, the DBS was switched off, how would we know whether or not the problem is technical or because it's simply not an effective therapy for a particular patient? So we need to know if the stimulation is on or off, and more importantly, the family needs to know if the stimulation is on or off. But there's an added complication because many of our initial cohort of children undergoing deep brain stimulation had non-rechargeable stimulators. And what we didn't realize, and that, as I'll show you later on, when the battery reached its end of life, it stops delivering adequate current to the deep part of the brain that stimulated the globus pallidus. And if you don't know that, then of course you don't realize whether it's the natural history that is taking over or whether it's a technical failure. So he's doing extremely well, and he goes from a state of not being able to walk, except with hands held, to a state where he is able to walk, and his dystonia keeps getting lower and lower, and his level of disability goes from unable to walk through to able to walk and go upstairs, not using the handrail. So from gross motor function classification system 5 to gross motor function classification 1. And his progress is literally down the motorway of improvement. And here we have a lot of different patients who have a different level of severity of dystonia, both the genetic causes, the acquired causes, and the progressive causes, each of them contributing to the data sets here. Practically 20 points of dystonia between each motor function level. Now, here,
operation because it's not as extreme as a lot of operations are. It's a brain operation, but compared to a lot of operations out there, it's not as major.
Now, Stephen is telling us that deep brain stimulation is not really a major operation. And he can tell us that because he's had the operation. But before the operation, he was extremely reluctant to undergo brain surgery. In fact, I remember he ran away. And although his situation was very, very difficult, he found it extremely difficult to confront having the surgery. Now that he's had the surgery, it's like diving off a very high board at the swimming pool or off a cliff into some rocky waters. He now feels able to tell people that they should consider having the surgery. And part of the process of advising people is to give them a full picture of what may or may not happen, but also that if you have deep brain stimulation, there will be responsibilities about how to look after and care for the stimulator. And most people feel happy to sign on the dotted line that of course, they'll look after the stimulator. But what happens several years down the line? What happens to that commitment to look after the equipment? And this is part of the question which I want to start raising amongst you all about the shared commitment towards looking after the deep brain stimulation. Now, unfortunately, being a tall and athletic young man, he got involved in a fight and he developed a bruise called a hematoma over the site of his stimulator, and it got infected, and he then had to have his stimulator removed. And 1 month after the non-rechargeable stimulator was removed, his dystonia returned.
And then back again, that's fine.
In anybody's experience, this is the worst nightmare they can imagine.
And do you want to turn the wrists round this way? That's it.
After moving so well and so smoothly, the reminder of how the dystonia can return is a terrible shock to the system.
Brilliant.
And he had a replacement surgery. The replacement surgery was not as effective. Now, I'm sorry, the replacement surgery was effective, and then he was visiting his girlfriend in Spain, where they have very low ceilings and doors, and he banged his head on the top of the door and he cracked his electrode. We were in Dublin at the World Movement Disorder Society meeting when he sent me a phone call to say that he was having to be airlifted back to the UK because his dystonia was so bad. Then he had the electrode replaced and it didn't work so well. Then the electrode was replaced again.
Fantastic.
Finally,
Stop.
finally he regained confidence.
Back towards me.
So all these are illustrations about what happens when the stimulator fails to work. In this situation, it's having to replace a stimulator, then having to replace a wire, and then finally getting the wire in the same position as it was the first time and getting the clinical effect. So there's no doubt that the equipment is playing an important role in maintaining normal function. Now here he is, showing a very nice erect posture with our 2 nurse specialists. And I normally take this as a moment to illustrate that not all children are small, but I can assure you that these nurses aren't short. And finally, because I was showing a lot of his early dystonia and response to DBS around the world, I wrote to him when he was out working, and he sent me a letter that he was leading a healthy life full of exercise, which he says makes things much simpler. And he thanked us for our help, and he said that it brought tears to his eyes watching how bent his back was, and that we could use whatever we liked to help other people with dystonia. And that brought tears to our eyes. So now I want to move to a more difficult area of dystonia, which is cerebral palsy. And this is an ex-preterm boy who is missing a part of the lower brain called the cerebellum. And he was born at 24 weeks, so that's 16 weeks early. And he has a very early motor disorder. And the problem is that he is also deaf. And the family want him to have a cochlear implant. And so they would like him to have his dystonia controlled so that he can use the cochlear implant effectively. So this is a really difficult combination of requests. First of all, can you do deep brain stimulation to control his movements? And then can you have a successful cochlear implant? So we go through the normal evaluation to show that his motor pathways are normal. Then he has the first non-rechargeable neurostimulator implanted in a child in 2008 on the 30th of December. This is a very large stimulator, and in those days we used to put it under the collarbone here. And as a result of this case, we've stopped doing it. Here you can see the electrodes nicely in position. And these are the electrodes superimposed on the CT brain scan, but also a functional scan that brings out the glucose metabolism in the brain that we had done preoperatively. And here he is before the surgery, and you'll see that he's cheerful, but also that he really can't stop moving. We call this dystonia with chorea, or dyskinesia for short. And the problem is that when you have a cochlear implant, you have to have a little magnet on the outside of your head, which allows the sound to be amplified and transmitted to the implanted cochlear implant. And this magnet has absolutely no chance of staying in place if you have such involuntary movements. And you can see here that he does have some involuntary movements. He's a little bit sedated, but in comparison to the movements which he had before, much less. And so he subsequently, about 3.5 months later, when we thought it was safe to implant another device, our main concern being the risk of infection, he had his cochlear implant. And during the surgery, we have to switch off the simulator so that the cochlear implant team know that they haven't damaged the facial nerve, and they record muscle activity from the face muscles. And at the end of the surgery, we have to remember to switch the deep brain stimulation on again. And so we achieve this triple neuromodulation, 2 electrodes in the brain and 1 electrode in the cochlea. And I've shown this so many times, some of you will be bored with this, but I'm always impressed by the power of neuromodulation. And here he is using his left hand to access a touchpad. He's wearing the headband that holds the magnet that allows an amplifier to stimulate the cochlear implant so he can hear. Here's my colleague, Dr. Małgorzata Kaminska, and she's holding the newborn child after both these twins have had their deep brain stimulation. Somehow the relief of the neuromodulation has allowed this child to be born spontaneously. And in fact, for 4 years, this deep brain stimulator is working. He is able to hear language. He's able to obey commands. He's able to listen to stories. And he can count on his fingers when he's asked to count on his fingers. And he can do a variety of things as a result of this deep brain stimulation. And then here he is looking quite grown up. And unfortunately, the stimulator, which is under here, has eroded through the skin, so it's been put a bit further away, and that site has become infected. And despite a long course of antibiotics, it has to be removed. And here he is about 10 days after the removal of his stimulator in status dystonicus, very much like the first case that I showed you. And although we were able to re-implant a stimulator 3 weeks later, it took 8 months for him to recover from status dystonicus, which is like a storm going through the brain. And of course, we needed a lot of medication, and we were able to restore his pattern of sleep and wakefulness, which was completely upset by status dystonicus. And finally, he was discharged home. And so I use this as an illustration about how the deep brain stimulator can do so much good, but if it's not functioning, or if it has to be removed, or if the wires break or get disconnected, then the dystonia will return in some, although not all. This is a young girl who was born at the same time as Thomas and was a preterm twin and had a severe movement disorder. Her brain imaging was really very, very reasonable, although there's a cleft here in the cerebellum, which may or may not have contributed to her movement disorder. It's difficult to know, although we should remember the cerebellum has what we call inhibitory effects on the brain. It is a control, a brake on the nervous system, and it controls a central part of the thalamus in this respect. Anyway, of course, she has a rechargeable stimulator in 2009, 1 year after Thomas, and this is still enormous, even though it's the smallest one in the world at the time. And this is how she was, and a few early clips. You can see she's still got short hair, and her movements were initially very hyperkinetic. This is 2.5 years after her DBS. She looks so grown up. And there's stillness and calm. Though it's true to say that in the years to follow, there have been periods when her movement control has been less good. And the reason I'm showing you this is that in October of 2019, she presents with 5 days of being in this condition here, status dystonicus, and she's been into her local hospital for some orthopedic surgery, during which time her battery goes flat. The parents notice the battery is flat and recharge it, but they don't realize that recharging the battery doesn't switch it on. You have to use the programmer to switch it on. And you can see here the severe jaw opening dystonia, which is very painful, the dystonia of the cervical spine, the arms, the discomfort and distress. And so as we switch her on, you'll notice that the facial expression has changed because the lips are together, the eyes are open. There's a look of calm surprise. And of course, it all seems like a bad nightmare. You've got to switch these off because otherwise they compete with each other too much.
Enjoy the trip home. Oh, now you are over here. Well done.
The story doesn't end there because in the relief of being switched on again, the information is transmitted to the special school where she's a boarder. And every day the staff use the programmer to check that the stimulator is definitely on. But on several occasions, she has to be taken urgently to the local hospital because of a worsening dystonia, and Dad goes down to check her out and finds that the stimulator is off. And what's happening is that, without realizing, when checking the stimulator with the programmer, the off button is being accidentally switched and the stimulator goes off. So following this, we recommended that parents and staff should only check the stimulator with the charger. And we'll come to this at the very end of this talk, of how to prevent the accidental switching off while checking the stimulator with the programmer. Now, when we started our neuromodulation program, we only had non-rechargeable batteries. And these were single channel batteries called Soletra or dual channel batteries called Kinetra. And we found, to our astonishment, that in our children, where we were using quite high currents and long pulse width, that the batteries were only lasting about 18 to 24 months. And as the battery reached its end of life, it stopped delivering an adequate current, even though we thought we were still delivering something. And so we then had to replace the batteries in quite a large number of children. And then, of course, there was an interruption to therapy. And as you know, it takes some time for the DBS to take effect, particularly if there's been a long period when, in fact, the non-rechargeable battery has not been delivering therapy. So this is a very confusing and difficult phase for any service. And this is why we were very keen to embrace the rechargeable battery system. And you can see that some children had to go through 4 implants before they got to the rechargeable. Not every family wanted to have the burden of recharging, but eventually everybody's on a rechargeable stimulator. So we've got a paradox in the sense that if the neuromodulator isn't actively stimulating the brain, it cannot function. And yet it is perceived that recharging a stimulator is a burden, and we have to persuade people to take on that challenge. So this is just a little bit of statistics from, I think, 2016, when we were looking at the complications of our deep brain stimulation service. And one reason why a stimulator has to be removed and the wires is that there's an infection. So overall, including all the children who'd had non-rechargeable stimulators, we had a 10% infection rate. That went down to 8.6% with the rechargeable stimulator. And that was down to 4.7% infection rate in children who were under 7, which in our experience shows that young children, smaller children, do not have a higher infection rate than older children, as has often been claimed in the literature. And so it's very reassuring. Of course, any piece of equipment can undergo a variety of problems which all need to be resolved, sometimes with removal of the equipment and replacement of the defective or infected part. But we also took some data on the battery being unexpectedly switched off, and these were the non-rechargeable batteries. We had an 18% unexpected switching off problem here, because the non-rechargeable batteries used to be easily switched off when in contact with a magnet, going through security gates at an airport or in shops or school magnets and so forth, which is not the case with the rechargeable stimulator, at least not to the same extent. And we also knew that in almost 5% of those, the children, we would get this terrible condition called status dystonicus when the stimulator was switched off. So this is not a benign process, it actually has consequences. Again, the reason for removal of a stimulator is often because of infection, sometimes 40% in some places, but we have close to an average of 10%, but 5% for the children under the age of 7. Now, I'd like to present some work which was presented by Dr. Sarah Butts, who is a clinical fellow in the Complex Motor Disorders Service, and it was presented at the beginning of January at the British Paediatric Neurology Association annual meeting. It's half a dozen slides, and I hope I'm not running too much over, but this is now looking at some of the detail about batteries being off and charging behaviors in children and young people. So the clinical illustrations have informed you about the possible effects of the unexpected reversible battery failure or turning off. And causes can be low battery charge or electromagnetic interference, largely the latter if you have a non-rechargeable system, but still. And regular observation of the DBS turning off may be caused by insufficient charging. And if your battery is under 25% charged, then you run a higher risk, as we will see, of the battery going off because of the battery being depleted. Many parents and carers are not necessarily aware of the possibility of being off or what the risks are. And as we will discover, many children are off for weeks or months. So from 2018 to 20, we actually tried to record the numbers of times that we found the DBS system off when the child or young person presented to clinic. So just as a quick physiological reminder, why is continuous stimulation needed? Because its action modifies basal ganglia output and results in neural reorganization, which we call plasticity. Oops, sorry. The dystonia may be completely suppressed after long-term stimulation, even when the DBS is stopped, and this has been found in a proportion of cases when they have had an observational study of being switched off under clinical supervision. And when there are no immediate effects of being switched off, even after days or weeks, it's because there's been some underlying neural reorganization that has actually given the brain the capacity to keep dystonia at bay. But sudden cessation of stimulation may become a medical emergency, and I've shown you 3 examples of that. And the advent of the rechargeable neurostimulator has prevented dystonic crises because we can guarantee and assure continuous stimulation for many, many, many years, in fact, 16 years now, with a single stimulator, possibly longer in a few years' time when the road testing will allow us to continue with the same stimulator, hopefully. And largely speaking, the rechargeable stimulator is associated with higher patient satisfaction, and we did a survey of that in 2012. And this is the data that we had back in 2017 based on the previous years, where there was only a 3.4% switching off in 129 children. But of those 3.4%, a quarter, the battery was completely depleted. In other words, had not been recharged. This has been shown in adults with a similar 3.6% fully depleted battery, causing DBS interruption. So we wanted to estimate the prevalence of battery failure. We wanted to estimate charging behaviors. We wanted to identify potential risk factors for battery failure. And we wanted to make an action plan to prevent and treat battery failure or deep brain stimulation off scenarios. So the first, so that we did two studies. One that is the DBS off study, and we analyzed the recorded events when the children and young people came to clinic between January 2018 and January 2020. And we found that there were 22 patients out of 122 that had been off. Of course, we are only as good as assessing those that have crossed our threshold, because those that don't come in that period for some reason, we may have missed. And then the second study is a survey, a monkey survey, in fact, of patients and carers and young people on their charging practices. And we wanted to compare the DBS off group to the never off group. In other words, we wanted to know, how do people manage their deep brain stimulators if they've been off? And how do they manage the deep brain stimulators if they're never off? And we managed to get 63 out of our 128 patients to respond to the survey. Now, I do apologize for all the data on this slide, but we're going to go through each column individually. So the number of times that the DBS was off, and this is the DBS off study, not the survey, 60% said it had been off once, 8% said it had been off twice, 20% said it had been off 3 times, and 10% said it had been off 5 times. And before 2018, just under 30% said it had never been off, but there were some that said it had been off, but the majority didn't know if it had been off. 55% didn't know if it had been off at all. How many days or what length of time was it off? Well, most, just under 30%, less than a week, 20%, a week to a month, 8%, 1 to 3 months, 25%, greater than 3 months, unknown for the 15%. How long after the DBS surgery was the stimulator off? And not surprisingly, if you've had the DBS for less than a year, it's very unlikely that the stimulator is going to go off. Everybody's hypervigilant, they're very good at charging. But as you go into the later years of DBS, 3 to 5 years, up almost 30% of children have a stimulator off value. If you've had it for 7 years, it could be 20% or more, 25%. Greater than 7 years, almost 20%. So the longer you've had your DBS, the greater the chance that you will have a stimulator off episode. Somehow, the length of time you've had the stimulation dulls your senses, and you become perhaps complacent or less attentive to the possibility of the stimulator going off. You take it for granted. Why not? If you're doing well. Now, deterioration in motor function is a sort of 50-50 situation. Here we've got 45 who say, yes, there's a deterioration in motor function. Another 10% saying some of the time, and about 40% saying, or 35% saying, they didn't think there was a deterioration in motor function. And again, this is a question of perspective, because you can have a deterioration but not go back to square one. And so you think that perhaps you haven't had a deterioration. 45% were not aware that the stimulator was off. So I think this is probably this group here. They are not aware that the stimulator is off because there's no dramatic change. They're not presenting to casualty in status dystonicus. But what is this, 50%, 55%, they are aware that the stimulator is off. In fact, I've had children saying that when they had the non-rechargeable stimulators and they went through security barriers, they would feel something in their vocal cords and they would tell their parents, I think the stimulator's off. And they would be checked, and yes, it had been switched off. So there are sensations and there are small motor feelings that give the patient a sentinel sign, but not in everybody. What was the cause of the stimulator being off? Well, look at this. Overwhelmingly a low battery. That's to say a flat battery in 63% of cases. Magnets, a little bit. Tragically, end of battery life in one case. What about the second time? Well, unknown for 15%, 25% a low battery, and the others we don't know. And how was it turned back on? 60%, the stimulator was turned on in the clinic. In other words, if we have a 6-month review plan and the stimulator goes off a few weeks after the last visit, then it may take 5.5 months before the stimulator is switched on again. That's far too long. This is not a good situation because it will give you uneven neurostimulation, and that very important impact of neuromodulation to help produce smoother, calmer, more effective movements will be derailed. But there are a proportion, about 30%, who have realized at home and have managed to switch the stimulator on, often after getting advice. So just to summarize the DBS off study, 18% recorded battery failure. In 40% of those, there was more than one event. Insufficient charging was the overwhelming cause of the stimulator being off. And just over a half experienced a motor deterioration when the stimulator was off, although half were not aware of the battery failure the first time round. When we looked at, well, what were the characteristics of the children and young people who had a stimulator off experience? We found that the average age was 15.5. The age at surgery was just over 9 years. And they were about 4.5 years following their deep brain stimulation. So this was they all shared the similar characteristics. The difference is that the girls, the older girls, had a higher chance of being off than boys. So you're more likely to be off if you are a teenager, a female teenager in your mid-teens. And there's no difference between types of dystonia, such as genetic dystonias or acquired dystonias. Now we're going to look at the survey of 63 respondents out of 128 patients. We were able to email 128 because we didn't have the emails of all 128. 63 answered. And we asked them 10 questions. And again, we have the same format as we had for the DBS off study, looking at a number of things. First of all, who is responsible for recharging? A third was the parents, 25% was the patient or child, 15%, 12% was the parents and carers, 25% was the patient and parents, and then a small proportion was the patient and carers. So lots of different combinations. The role allocated according to what seems sensible within the family group and the extended caring circle. Frequency of recharging, was generally every day for a third, every 2 to 3 days for 10, 20, 30, 40, 45% of cases, once a week for 15%, and less than once a week for 6% of cases. Duration of charging less than 30 minutes for a third, less than an hour for another third, more than an hour for the third. So it's quite interesting that there is a differentiation between the speed of charging, or the amount of time spent charging. What about the difficulty maintaining connection between the charging device and the stimulator? Just about 25% said they never had a problem. A very much larger group, 10, 20, 30, 40, 50, 60% said they did have connection issues. And that begins to ring a bell about where some of the difficulties may lie. How do you maintain connection? Well, in a quarter, it's a handheld process where somebody, can be the patient, can be a parent, can be a carer, holds the charging plate over the stimulator. Now, all the stimulators, except for a handful, are in the abdominal position now. They're no longer under the collarbone because we don't believe that this is an anatomically suitable place to put a stimulator in a child. Quite a few families and young people just stabilize the stimulator under the clothes and let the clothes hold the charging plate against the stimulator. About a quarter use the charging belt. Some of them use a sticky tape disc that holds the stimulating plate, the charging plate on the skin. And others seem to do nothing at all, which means that the patient must be either lying flat on the bed and not moving. Difficult to know how that charger is going to do the charging. Now, what is the battery level at the start of charging? Well, there's a proportion of children whose battery level is between 0 and 25. These can easily be the people who are definitely flat when they're charging. But you can see that other people are in a much more safe zone. So we would say the best charging is when you go from 75 to 100%. It's obviously safe to be between 50 and 75% charged. So this group here are keeping their batteries in a safe zone of charging. And then in the survey, we asked the respondents, has the battery ever been turned off? And 60% say never, just under 20% say once, and just over 20% say 2 or more times. So we've got here a 40% off response. And now this is an important column because it's looking at what we call the care burden of charging. Did the patients and carers believe that there was a burden involved with charging? I know 35% say no, there was no burden, but 45% said there was a little bit of burden, and 20% said there was quite a lot, and then 4% said there was a great deal of burden. And again, if you're in this group here, the chances of being in this group here and the chances of being in the stimulation off seems more plausible. So we found that 19 of these cases had been off. That was 53% more, and 53% had more than one event of being off. We found that these patients were charging every 2 to 3 days or longer intervals. And you'll see that the charging time fell into the law of thirds. A third were charging for 30 minutes, a third for just under an hour, and a third for over an hour. And there was an association between people who reported charging when the battery had fallen below 50% and were also reporting a high care burden, as they called it. I should put high care burden in inverted commas because that's what they responded. So the risk of battery failure, or relative risk, is that you're almost twice as likely to be off if you're greater than 15 years of age. You were 2.5 times likely to be off if the child or young person was responsible for charging. 3 times more likely to be off if you were charging less than once a week. 2 times more at risk of being off if you had difficulty maintaining connection, and 2 times the risk of being off if the charge in the battery dropped below 50% before you started recharging, and just about 1.5 times higher risk of a battery being off if there was a sense that the care burden of charging was high to the child, family, or carers. So this is our summary. I don't know if you can read the headings there in orange. I think there's a bar here, which I don't know if we can move. So this is the DBS off survey, and this is the monkey survey. And all the patients now have rechargeable simulators. We had an 18% recorded off in our clinic and a 30% recorded off in the survey. 40% of our clinic caseload was off more than once, but half was off more than once in the survey. So it shows that what comes through the clinic door isn't necessarily an accurate reflection of what's actually happening in real life. And in our DBS off, we found that insufficient charging was likely to be the most common cause of being off. Looking at those that we detected being off in the clinic, we found that there were more females in the off group. There wasn't a statistically significant difference between acquired and genetic dystonia. So slightly higher, it looked higher, but it wasn't significant. And they were of similar ages, whether they were on or off. Half of this group experienced deterioration in movement disorders. Half were not aware of the battery failure. And many of these were people who'd made remarkable progress, for instance, writing with their feet, not able to use their arms when they presented, and then were able to use their arms, had improved speech and other things. So very dramatic changes, and yet sometimes we're not aware when the batteries were off. And 36% had been off more than a month. The risk factors for the survey were that the family had agreed that the patient, the child, young person was charging, but they ended up charging less than once a week. Now, there was another remarkable piece of information we discovered, that in those families and children who had never been off, about 1/5 of the group didn't know how to assess if the DBS had been off, and almost a half didn't know how to switch it on if they were to discover that it was off. So my last 2 slides are part of the information that we have supplied to help people realize what's going on. So the first thing is to realize that when you see the symbol here in the top left-hand corner of the charger without the lightning bolt, which I call the Harry Potter sign, If the Harry Potter sign is missing, the DBS is off. If the Harry Potter sign is present, the DBS is on. So when the patient or the family are charging, they're always asked to look for the Harry Potter sign overlying the stimulator. This is the indication that the battery is 3/4 full. If it's half black, half white, that means it's 50% full. If it's a quarter black and 3/4 white, it means it's only 25% full. And if it's completely white, it means it's empty. We'll see that in the next slide. Now, it says that your charger cannot turn the DBS back on. You can still charge when the DBS is off. Charging will not turn the DBS back on, so go to step 2. And step 2 is to use the programmer, and you need to switch it on using this gray button. Now remember, we had one case where the DBS was switched off because in an attempt to check the stimulator with the programmer, it's quite easy to mistakenly press this button. So when the stimulator is on, you press this button, it will switch it off. When the stimulator is off and you press this button, you'll switch it on. So we now recommend that families only check their stimulators with the charging system and only use the programmer if they need to switch the stimulator back on. Now, as I speak, I know that there's a new charger, a cordless charger coming through. So we will have to update all this information according to the new equipment. But we also supply this sheet here, which is to remind people that what they're looking for is a battery which is 50 to 100% full. We like the battery to be in this zone, not in this zone, because this is the dangerous zone. We want the families to see a fully charged battery at the conclusion of charging, which I must say is probably unlikely if they're finding charging a care burden. We never want them to see this. We always want them to see the Harry Potter sign. So now I would like to open this up for discussion, because I believe that what we have been discussing is the interface between an expert service and high technology with the reality of living both with dystonia and both with deep brain stimulation. And in order to make this a successful neuromodulation program, we need to ensure consistent DBS stimulation and DBS management, which means charging. And I think that there are many different aspects of this process that we need to work on, not least making families and their care and their children's carers aware of what the risks are of the DBS being off, but also how to not be afraid to check the system and then know exactly what to do about switching the system on. It's more complicated when we're talking about mid to late teens and early 20s in young people, because independence is such an important thing. But we've had quite a few people who are studying higher education or in apprenticeships, and they complain of feeling unusual. And then we find that the stimulator has been off. And then we go through an education program. But there is a deeper aspect, I think, to the neuromodulation, which is that when you have emerged after a period of severe dystonia and your dystonia becomes much improved, you can hardly ever imagine the dystonia returning. In fact, you almost feel as if you've been completely cured. And part of the mind, I think, wants to put the dystonia, to bury the dystonia forever as a nightmare. And that may lead to a situation where even having to manage recharging is a reminder of the dystonia. So there's something much deeper about why it is that people neglect to discharge or allow themselves to be very close to the margins where a DBS off situation can occur. So thank you very much. I will finish off here with these words. The incidence of reversible battery failure in this study was higher than previously reported. And of course, the aim is to improve charging behaviors in the DBS population to prevent discontinuation and promote long-term effects of DBS therapy, which is, of course, neural reorganization. And I'd like to thank Sarah Butts again for having prepared the data, and it's been published in abstract form in Developmental Medicine and Child Neurology, presented at the British Paediatric Neurology Association, and will, I hope, appear in full paper format in the very near future. Thank you.
Okay, so thank you, Dr. Jean-Pierre, for your great presentation. So I give the floor to Kasia now.
Thank you, Dr. Lin, for this great presentation. It was very interesting. So we gathered some questions, and I would like to start with the age. So from your experience, what was the youngest child that you've implemented the DBS system?
The youngest child was 2 years and 8 months, and that was in May 2019. A case of GNA01.
Okay.
Intensive care for about 6 to 8 months. Yeah.
And from your experience, obviously, do we need to know the genetic results, or so do we need to have the diagnosis, or is it DBS also for those children that does not have the diagnosis, but they have generalized dystonia?
It's always good to have a genetic diagnosis, but you know, since 2005, we have discovered new genes in some of the patients who've had DBS with us for more than 10 years.
Mm-hmm.
You know, and I think the problem is that you have research labs that make diagnoses, you have clinical DNA laboratories that go through panels, and between them, they still can't diagnose all the cases. So you have to go on clinical grounds. The whole process of neuromodulation depends on the integrity of the brain and the interconnectedness of the brain. The more connected it is, the better chance that DBS is going to work. So we've had this process now for almost 20 years where we make sure the corticospinal tracts are functioning using transcranial magnetic stimulation. There's no point doing DBS if you've got delayed central motor conduction. We did do it in some cases where there was delayed conduction to one limb, and we've got data on that now. We've published a machine learning paper on selection using this whole idea of what happens when you have abnormal central motor conduction. We've also done the reverse simulation, which is the somatosensory evoked potential, because we believe that the sensory information handling plays a role in the development of dystonia. Now, even if your somatosensory evoked potentials are not disrupted, the central processing of sensory information may be disrupted. And Verity McClelland, my neurophysiology colleague, has been working on this, and you'll be hearing more about that because what is the brain able to do with that sensory information once it reaches the brain via the thalamus is the big question. So those are two things that you can do in order to, if you like, you don't have a gene, you suspect there's or you know that there's an acquired reason, you want to know are the principal pathways from the brain and to the brain functioning. Mm-hmm. And then, of course, for a long, long time, we've known that a normal looking brain on neuroimaging is a very good it's not a perfect, but it is a good proxy to deciding whether or not this is you're likely to be dealing with an idiopathic or genetic dystonia.
Mhm.
And of course, that's why we've operated on cases of GNAO1, KMT2B, FAP1, all of these things before we knew we could test for them at all, you know. And now ATP1A3 and other cases. There are lots and lots of causes of dystonia. Most CP populations are going to have genetic dystonias in them, and people are going to wake up to that. So it's great if you can have the genetic postcode.
Yeah, it's obviously not necessary to proceed with the operation, because we can help our patients with the with, let's say, symptomatic treatment, even if we don't know the underlying genetic cause, even if we suspect that it is, right?
You have to be clinically courageous and not foolhardy.
Yeah, exactly. So what are the most common complications that you experienced with the DBS? But I mean, with the electrode implementation, the question was about the infections, but I think that we can go a bit wider than the infections.
Yes, I mean, you know, it's with a heavy heart that we have to counsel every family. You know, we, after all the preoperative evaluation, the education, the hopes and everything else, it may be that an infection will set in. I have to say that our infection rate has gone down even further, although we need to analyze this, since the antibiotic impregnated mesh has been used. So at the time of implantation, an antibiotic mesh is a little bag is put over the stimulator, and that's implanted together with the stimulator. And that seems to have had some kind of impact, though we need to get the stats out of that. Because if you get rid of the, say, 5% risk of infection in the under 7s and the possibly 8.5 in the older than 7 cases, then that's a big bonus. We've had interruption of therapy through a rise in resistance in the electrodes or the or in the accessory wires. And normally we try and resolve that by doing an exploration. Is it a disconnection or not? We do x-rays to make sure there isn't a fracture. And we've also had a situation in a handful of cases where the electrode has slipped out of its target. Mm-hmm. Normally we think about this as happening with growth, but it's not necessarily with tall people. Mm-hmm. We certainly have seen it in a few cases who become athletic and take part in sports and do all sorts of things. We've had cracked electrodes by the head being hit or by a ball falling on the head. These are things that happen. But by far the biggest cause of interruption of therapy is a flat or depleted battery. Mm-hmm. Mm-hmm. And we can prevent that. Yeah. And we can correct it by switching the system on again. We've had one late teenager whose battery was off for more than a year and couldn't be switched on again and had to have a replacement, which is something that I hope won't happen again.
Yeah.
In a long time.
And what about this transition from being a child to the adult one? So if the child has the DBS system implemented, then how is it growing with the child, or do we need to replace the electrodes? And so what is recommended?
No, I mean, it is quite remarkable. I showed you Stephen, who's 7'4". Now, what is that in? That's 186 centimeters, I think, tall. He obviously had his batteries changed and his wires changed once or twice for other reasons. He got involved in the fight, he got infected, you know, and so forth. But no, actually, what we do find is that a fibrous sheath forms along the electrode, particularly the extension lead, and they may complain of there being a tethering, so the neck feels as if the freedom of movement is not as good, and you need to loosen the sheath to allow the wire to be fully mobile. The extension wires are very long, and in smaller children, they seem to have too much wire, but they need it later on when they grow. Yeah. So obviously there is an issue with the under 5s that we implant. Exactly where do we put all the extra wire that you have because they're not tall enough and things. And I think here we've got the balance between early intervention, remediation of the dystonia, giving the opportunity for motor development versus the technical issues of the equipment. So of course, in my imagined perfect world, the simulator should all be cranially mounted. The neck is no longer part of the equation. The chest isn't part of the equation. The abdomen isn't part of the equation. And because it's on the head, when you're growing taller, it's not going to have a problem.
Yeah, that's perfect.
But of course, we need to have those systems. And of course, the other thing that we need is closed loop systems. Systems that record from the brain as well as stimulate and then self-adjust. I'm not asking for too much.
Yeah, it would be really perfect. And so what about the training and education programs? So if the child is getting his DBS, then is there any specific training for parents, or if the child is already a teenager, they have, is it anything for them?
Well, I mean, this is the reason why we did this survey, because we need to understand it not from our point of view, but from the consumer's point of view. And not just from a parent's point of view, but from a child's point of view. And this is where I think that Dystonia Europe and Dystonia UK and all the dystonia societies, the national societies, you know, could harness their expertise and the reach which you have in order to produce materials that will make this easier for families and easier for children, easier for young people. And I'm thinking about the Dystonia app. I'm thinking about focus groups whereby the young people are themselves directing the knowledge and know-how and explaining it and discussing it in a way that doesn't seem as if they're being talked to. It's another thing I've got to do. Wipe my feet when I get into the door. Put the dishes in the dishwasher. Do my homework. Stop being online. You know, not seeing your friends so much and doing a bit more charging. I mean, all of this is just a nuisance. So we have to have means of allowing the information and the practices to be actually second nature and not to be a burden. So I'm really looking forward to the support groups to help guide the best practice, if you like.
Yeah, that would be really, really lovely. And I think that it's also good to connect with those people who have dystonia, and it's also good for them to have this community-based programs that will also help them with networking and overcome with many other obstacles that they need to foresee in their lives. Okay, so I have the last question, unfortunately, and this is actually it might be difficult because this is from patients from Romania who had their DBS implanted abroad, and now they need to have the battery replacement, which is not available in their country, so in Romania, and they are also not able to go abroad. So the question is, do you have any advice for them, or who should they contact in order to have it done?
Are you saying they can't go abroad because of COVID?
Oh, I don't know, actually. It was just said that they can't go abroad. So it wasn't specified whether it's because of COVID or financial issues or any other things that could come up.
Yes, I mean, I think there's a situation where neuromodulation is such a service-based medical and surgical intervention. Without the team around the patient who's got a neurostimulator, neurostimulation isn't really going to be that effective, or is not as effective as it should be, because the team is there to be the eyes and ears and troubleshooting. It's a partnership, really. So it's very important that in countries where there isn't such a team, that a team is created as soon as possible. Now that sounds like Never Never Land, but it's very important. Secondly, I think that we ought to consider to what extent the neuromodulation industry can support or cushion the issues so that they can help different countries address the issues of whether they have a neuromodulation program that's officially supported by the healthcare system in that country. I think we still have to use those good offices, and then we have to consider the upshot of the humanitarian issues around offering service, and that's more difficult because healthcare services are very, very careful about how they practice and what they accept. So these are all soft ways of improving the care of neuromodulation in different countries where we know that access to healthcare may be difficult for very simple care, let alone complex care. But I think the dystonia organizations, I think we do need to look at how we can support this. There is, on the one hand, plenty of wealth in the world that isn't terribly well used, and maybe we can get means of supporting some of this activity by getting people who want to sponsor good works to sponsor this in some way.
Yeah, I just Googled that they have a DBS center in Bucharest. Probably those patients know that, but perhaps maybe this is a good direction to get in contact with someone who is responsible there for the DBS, and maybe it will be possible to get the new batteries.
Well, I would like to say that having links with established DBS centers and having a training program, it's not so much a training program about how do you put a deep brain stimulator in, is what is the potential for deep brain stimulation in different patient groups. I know that Nathalie d'Horizon is on the line, and she created a DBS center in Paris not that long ago. I can see that Marcela Montiel is on the line from Chile. No, I think it's Chile. I see Eric Yao in Hong Kong. He was one of our clinical fellows a few years ago. Hello, Eric. It's fantastic to know that you're there. It's a question of framing the basis of offering neuromodulation in the non-adult group, non-Parkinson's group, in dystonia, and there's, the neuromodulation for dystonia is still rare in comparison to neuromodulation for Parkinson's disease. And so it's a question of removing barriers that are there because of, lack of enough clinical exposure and conversation.
Yeah, true. Okay, so thank you very much. That's all the questions that were sent to us. Thank you very much for engaging in this conversation. Professor, thank you very much for answering all those questions.
I wave to the people that I think I know, but yes, I mean, from Hong Kong to Chile, that's quite a good, that's the world, isn't it?
Yeah, this is the advantage of the webinars that are put online, right? That you can connect from every part of the world. So
well,
that's
it depends how you go around the world, because Hong Kong to Chile is maybe close, but if you go around the world in the other direction, then it encircles the whole world.
Yeah, the problem is the time zones. Yeah, for some people it's a middle of the night, and
I know.
That's why we are also recording the webinars, and all the webinars, including that one, will be uploaded to our YouTube, Dystonia Europe YouTube channel, and Dystonia Europe Facebook page. Yeah, so for those who want to watch it again or share with your groups, for those who couldn't join today, that recording will be uploaded soon on our socials.
I would like to say thank you, Jean-Pierre. Very interesting presentation. And I was actually quite surprised about the different surveys and studies and the result. And I didn't know that there was that there is this issue with the batteries, and I think that information and education really important, and if there is something that we can do from the support group, I think it's really that's necessary, because these children or young people who have DBS shouldn't run this risk of not having the technical system working for them. So education, training, support.
Yeah.
I was also thinking about this thing about that there is no alarm within the device going off when there is something wrong, if there is low battery, or if there is or if it's turned off. There is no signal, or
yes, I think there's a number of things that seem to be not too complicated, and of course you have to remember that there are now several devices.
Yeah.
So across the board, each of the devices will have their own special peculiarities and technical issues. So I think that, but I think as DBS becomes, I'm not going to call it routine, but more prevalent, I think we do need to address this issue of the maintenance and the performance, the ongoing performance, optimal performance of the device as a very key issue.
Yeah, because looking at those slides where you showed the instructions and what it looks like, it looks quite complicated.
I know. It's
and this is for normal people who are not maybe always very technical. I mean, maybe you don't have a technical interest.
Well, all the families get a booklet in 13 languages.
Yeah.
I'm astonished at the numbers of parents who of bringing through the booklet, and they are completely, totally, they understand everything that needs to be done.
Yeah.
You know, there are the booklet readers and the people who are the plug and play people. And they're different. I do think that we do need to now begin to engage a partnership with the with industry, but industry and the support groups and so forth, and we get the people, the consumers, to help guide the types of materials that work. But also, I think your app, you know, to take you directly to a what if section, and, you know, and then troubleshooting, and then have some simple videos that say this is how you do it. Instructional.
Definitely things to work on.
Yes, thank you very much.
Okay, so thank you again, and we will see each other again, I think, in February. We plan for our next webinar. We haven't decided exactly the topic, and
that will be surprise.
Yes.
It's a surprise. So can I just ask, in terms of you know, other people who might want to join a webinar, how do they log into a webinar if there is one?
So we are posting a link to the Zoom webinar on our social media. So in the day and date and time of the webinar, they just need to click to that link, and they will be redirected straight to the webinar.
And also on our website, under the calendar of all our activities, what is happening, there is also the Zoom link to the webinar.
So that can be, if we receive the link, or if we're aware, we can send it to anybody that we think.
Yeah. It's universal link, and anybody can use it. And also, if you subscribe on our website to our newsletter, we are sending invitation to the webinars also to all our subscribers. So then you can receive an email also with the link. So that's the ways. But yeah, if you have a link, you can share it with anybody, and anybody can join.
Excellent. Thank you.
But then all of our webinars are recorded, and then they are posted on our YouTube channel.
Yes.
There you have all the webinars, and you can go back and look at older ones, and you can share those as well.
Yes, thank you. Lovely.
Okay, so I just want to thank you, Dr. Jean-Pierre and Dr. Kasia, for sharing part of your evening with us. And we are grateful to you for the work that you do every day and helping with the Dystonia community. I want to thank very much our participants for your questions and time. I also want to thank our partners who have been supporting us to facilitate this webinar and all others. And as I mentioned, this webinar is recorded and will be available on Dystonia Europe channels. So thank you, everyone, and we look forward having you at our next webinar. So thank you very much, and have a good evening.
Thank you very much.
All right.
Thank you. Bye.
Bye.
Thank you. Bye.